Hello, I'm Dr. Russell Barkley. I'm a clinical professor of psychiatry at the Medical University of South Carolina. Welcome to this internet course on the assessment of ADHD in children and adolescents. Before we begin, I would like to show you my sources of support for the previous year so that you can evaluate whether or not there is any conflict of interest that may exist with the contents of this program. I'm retired from the University of Massachusetts Medical Center, but I am not retired from clinical practice or teaching, as is obvious. During the past year, I've spoken for a number of associations, hospitals, and healthcare organizations, as you see here, for which I have been paid. I also receive royalties for a variety of products that I have in the marketplace related to ADHD, such as books, videos, newsletters, and courses such as this one. And finally, I have spoken for or served as a consultant to a variety of pharmaceutical companies that have ADHD medications in the marketplace. During the past year, I also served as an expert witness for the Eli Lilly company in a patent lawsuit. Now, as I've said, this course is about the evaluation of children and adolescents with ADHD. A major source used in this particular program is my handbook for diagnosis and treatment that you see referenced at the bottom of this slide. To begin with, let's consider what the goals of the evaluation are likely to be. First, obviously, to determine the presence of ADHD and to differentiate it from any other disorders that may result in problems with inattentiveness. Many disorders produce problems with inattention, such as bipolar disorder, anxiety disorders, and depression, and so we need to differentiate whether ADHD is the best diagnosis to account for the symptoms that might be present, such as those of inattention. A second purpose of the evaluation is to establish whether or not there are any comorbid disorders that may coexist with the child or adolescent's ADHD. We know that more than 80% of individuals with ADHD are likely to have another disorder, and more than half of them are likely to have two disorders. And so it isn't just an issue of differentiating ADHD from another disorder, but determining the number of disorders that may be present in a given clinical case. Another purpose of the evaluation is to evaluate the presence of psychiatric disorders that may exist in the parents and that might be affecting the child's adjustment or that might potentially interfere with the child's treatment. Now, obviously, making this determination is based in part upon the appropriateness for a particular setting. Private practice clinicians, for instance, and those working in mental health clinics may well be able to proceed with the evaluation of parents, or at least with screening them, to determine the presence of possible psychological disorders. On the other hand, personnel working within school systems, particularly public school systems, would not find this to be an appropriate goal for their particular evaluation of a child, which is to say that parents in such settings should not be screened for their psychological disorders and may well not tolerate or consent to such an evaluation. Another goal of the evaluation is to establish the domains of impairment that may exist and determine the priority of those domains in receiving particular treatment. ADHD interferes with a variety of domains of major life activities, such as family relationships, the development of adaptive behavior or self-reliance, social relationships, such as relationships with peers, educational performance, and so on. One goal of the evaluation is to determine which of these domains is impaired, to what degree, and also to determine their severity, which will have some impact upon the priority in which those domains are addressed. Additional goals of the evaluation include determining the profile of the child's strengths and weaknesses that might be used in treatment planning. For instance, if a child is particularly good at athletics, it might be important in the treatment plan to encourage parents to enroll this child in a variety of athletic outlets, such as sports, clubs, or other organizations in which this child might participate with some success. that success might help to counterbalance some of the negative feedback the child is receiving from other domains in which they are not performing well, such as in their educational performance. Now also, one goal of the evaluation is to delineate the types of treatment that the child is going to need to address not only their symptoms, but also their comorbid disorders and the various domains of impairment that one has identified. And then, of course, it's very useful to discover what resources are at the parent's disposal within the community in order to address these particular issues. Parents in rural areas may not have access to the same kinds of services in that region that parents living in urban areas are likely to receive, such as, for instance, with behavioral parent training or receiving consultation from a child psychiatrist. Now, it is also necessary to determine whether or not a medical evaluation is appropriate. Often it is, first of all, to rule out potential medical disorders the child may be having that could be contributing to some of their symptoms, such as sleep disorders, otitis media, or other difficulties that might be interfering with the child's attention span. The medical evaluation is also necessary as a prerequisite for starting medication. In that case, the medical evaluation is being used to rule out other conditions that might contraindicate the use of medication with this individual. Now, the assessment is also being done to determine whether or not there are any legal issues involved with this child or family, and the extent to which this evaluation is going to play a role in those legal issues, such as in custody disputes, or in evaluating the family for potential abuse of the child, if this is a court-ordered referral. Or it may involve whether or not the child is eligible for receiving various services, such as special educational services in the public schools. So the clinician needs to determine at the outset whether any legal issues exist in this case, and if so, how this report or this evaluation is going to play a role in them. Now, at the time of the evaluation, or at least at the time of the initial referral for the evaluation, the clinician is going to gather a variety of pieces of information about the child. In our clinic, we like to do this at the time that the phone call is received in the clinic requesting the evaluation. Often we have secretarial staff or other clinic staff gather this information from the family at the time the phone call is received, such as demographic information, the reason for the referral, who initiated the referral and why, the existence of any other evaluations that might have been received in the past, and getting permissions to release those evaluations for this current evaluation, any previous diagnoses that the individual has received and what they are, and then, of course, has the child or family received any prior treatments, or are they currently receiving any treatments for various mental health disorders. We also like to determine whether the child is receiving any special educational services at school and what type those services might be. Of course, it may be useful at this point or later during the parent interview to determine whether other family members have previously received mental health treatments or are currently doing so. This can sometimes help with differential diagnosis. For instance, if we know that certain family members are receiving treatment for bipolar disorder, it may indicate that this child has a higher risk for bipolar disorder, and that would be important information to know as part of this diagnostic evaluation. Depending upon the setting, of course, one would need to gather information about insurance coverage to cover the cost of this evaluation. Now, in school settings, or even in mental health clinics where these services may be provided at no charge, that issue is moot. But in private practice settings, determining the presence of insurance coverage is very important. Before discussing the particular methods that might be used in an evaluation of a child or adolescent for ADHD, I like to teach individuals that it is the issues that determine the methods. It isn't simply having a battery of methods available that one gives to each and every patient coming through the door, regardless of the issues involved. Psychological evaluations for ADHD can be very expensive, and therefore one wants to limit the time to the collection of information and the use of methods that address particular issues involved in that case. For instance, a variety of issues are likely to arise in the evaluation of someone with ADHD. These issues might be the current concerns about the child, of course, their history, particularly their onset, course, and their episodicity or periodicity, which is to say, is the course chronic, or are there periods of remission, either in symptoms or in impairments? One also wants to determine the presence of ADHD relative to other psychiatric disorders. This, of course, is an issue of differential diagnosis. And then one needs to determine the developmental inappropriateness of the individual's symptoms, because the severity of the symptoms is also a factor in the diagnostic criteria for various disorders. And then, as I've indicated previously, ADHD is often associated with other comorbid disorders, and therefore assessing those comorbid disorders can be just as important an issue as assessing the patient for ADHD alone. Now, impairment is a criteria for every Axis I mental disorder, and so one needs to establish that impairment is present, and in how many domains it is present, and to what degree. And so one will need to review with the family a variety of domains such as family functioning, social relationships, school functioning, and so forth. Another issue, depending upon the setting, is the parent's own psychological adjustment. ADHD is a strongly genetically influenced disorder. Therefore, 25 to 35% of the parents of ADHD children are likely to have the same disorder. Research shows that the parent's disorder can interfere with the child's adjustment, increase the likelihood the child may develop oppositional or conduct disorder, and interfere with the child's treatments, such as with the parent's likelihood of responding to behavioral parent training, or the parents being able to coordinate a home school behavior modification program, and so forth. So another issue may also be surveying the family and the child for their strengths and weaknesses, as I've already mentioned. And in addition, one needs to map out the community resources available to address the particular family's concerns. And then finally, we need to determine whether or not there is going to be a need for other professionals to conduct evaluations with this patient, such as physicians, psychiatrists, psychologists, social workers, occupational and physical therapists, speech pathologists, and so on. So there is a need to determine whether or not the evaluation needs to be multidisciplinary. But back to the question at hand, and that is, what methods should be used in the evaluation for ADHD? And the answer is, what methods would address these particular issues? Whatever those methods are, they are the methods that are used in this particular evaluation. Let's take a look at each of these issues and what methods might be used in the evaluation. Consider, for instance, what method is necessary to evaluate the current concerns the family has about this child. Obviously, the answer is an open-ended, unstructured interview that gives the parents plenty of latitude to describe why they're requesting this evaluation and what their current concerns are. Also, it provides an opportunity to discuss any other issues besides ADHD that the parents may have on their mind. The second issue is the history of this child, and particularly with regard to their symptoms. What method would be used for this? Obviously, a semi-structured interview that begins to focus more on the onset of the symptoms, their course, whether or not there are any periods of remission. This semi-structured interview appears in my ADHD clinical workbook, giving you some guidance as to the kinds of questions you might wish to ask. Now, obviously, differentiating ADHD from other disorders that produce attention problems is a major issue in the evaluation. There are several methods that a clinician can use to address this issue. The first is using broadband rating scales, such as the Child Behavior Checklist or the Behavioral Assessment System for Children. We often mail out these rating scales to parents and teachers prior to the day of the appointment to ensure that they are back in the clinic and scored and in the chart for the clinician to refer to on the day of the initial evaluation. These rating scales provide an indication of the presence of various types of psychopathology in children, such as the existence of depression, anxiety, ADHD, aggression, social problems, and so on. In addition, differential diagnosis can be assisted by doing a structured interview that contains the various diagnostic criteria for other disorders in addition to ADHD that the child is likely to have. For one such version of a structured interview, refer to my ADHD clinical workbook, where you will see an interview that we created that contains the DSM criteria for those disorders likely to be present along with ADHD in most clinical cases, such as oppositional defiant and conduct disorder. Now, in addition, besides using broadband rating scales and structured interviews of DSM criteria, the clinician needs to have a thorough grounding in their knowledge of various child psychiatric disorders. This is going to be needed in order to be able to conduct an appropriate differential diagnosis of ADHD from autistic spectrum disorders, bipolar disorders, anxiety, and depression. If the clinician has no idea what the nature of those other disorders are and what their diagnostic criteria are, they're not going to be able to conduct an adequate differential diagnosis. For this reason, the evaluation of ADHD is often done by mental health professionals with specific training in child psychiatric disorders, such as child clinical psychologists, child psychiatrists, social workers, school psychologists, who may have training in child psychiatric disorders to conduct such a differential diagnosis. Now, another issue in the evaluation, as I've mentioned, is determining the degree of developmental inappropriateness of the child's symptoms. Now, here we ask what methods are necessary to make that determination. Obviously, the structured interview I've already mentioned could do so, because it's going to go over the various symptoms of the disorders, and depending on the number of symptoms the individual has, gives a good index of the degree of inappropriateness of their symptoms. In addition, this is where one can use ADHD-specific rating scales that can help to measure the severity of the child's symptoms in comparison, that is, to norms collected on a U.S. normative sample. Two such rating scales would be the ADHD-IV rating scale by George Dupaul and the Connors Child Rating Scales. Both of these scales have parent versions and teacher versions, and both have norms for a U.S. population of children broken down by age and sex. Obviously, there are other such rating scales, such as the Vanderbilt ADHD Rating Scale, or some people might wish to use the ADD-ES or other such scales. But I happen to prefer the ADHD-IV scale or the Connors scales because of their normative data. Now, some clinicians might wish to use neuropsychological testing at this point to determine the severity of the child's difficulties with attention and inhibition. For instance, they might wish to use a continuous performance test to do so. But research shows that these tests have very limited utility and should not be used for diagnosis of ADHD. Here's the reason why. First of all, the tests do have good positive predictive power, which means if an individual obtains an abnormal score, they are likely to have some disorder present. Unfortunately, these tests cannot tell you what the disorder happens to be. Many disorders are likely to interfere with continuous performance tests or other neuropsychological tests besides ADHD. So the presence of an abnormal score does not necessarily mean that ADHD is present. For instance, some studies that I have conducted indicated that if an abnormal score is present, there was only a 60 to 70% likelihood that the child has ADHD, even though there's about a 90% likelihood that some disorder is present. So one would have to go on and do a structured interview of various disorders to determine which ones the child has. But the most compelling problem with these psychological tests is that they have very poor negative predictive power, which is to say that they produce too many false negatives. In other words, an individual may obtain a normal score on these tests, but that does not necessarily rule out them having ADHD, because many individuals with ADHD, particularly if they have a comorbid anxiety disorder or internalizing disorder, can pass these tests. So therefore, abnormal scores may be meaningful and indicate that some disorder is present, but not necessarily ADHD. But normal scores are meaningless, which is to say that they cannot rule in or rule out whether or not ADHD or some other disorder is present. Therefore, I do not recommend the use of neuropsychological testing or continuous performance tests for the diagnosis of ADHD, whatever other value they may have in addressing other issues. Now, another issue to be addressed in the evaluation is the extent to which the ADHD symptoms are pervasive. Now, this can be done with a parental interview in which one asks the parents about various situations in the home or community, or one interviews the teachers about various situations there in which the child may be having difficulties. The diagnosis of ADHD requires that your child be having difficulties in at least several situations, such as at home, or in school, or in the community. Another way of making this determination is to use the home and school situations questionnaires that I developed many years ago, and which can be found in my ADHD clinical workbook, along with scoring instructions and norms for these questionnaires. Now, all disorders require that impairment be present in order for a diagnosis to be given. How does one determine the presence of impairment? This can be done through an interview with the parents about the various domains in which the child is having difficulties, such as in social relationships, educational functioning, or family functioning. This can be done with an interview with the parents and teachers, and you'll find such an interview in my ADHD clinical workbook. But you can also use some rating scales to get some idea about the presence of impairment. For instance, the FACE page on the Child Behavior Checklist does contain questions about friendships, peer relationships, school functioning, grades in school, and so on. So does the FACE page of the Behavioral Assessment System for Children. So either of those might be used to get some global indication about possible impairments the child may have. If the issue is social relationships, then the social skills rating system can be used to get some idea about impairment in those domains. This rating scale also asks about behavioral problems besides social skills, and so it might indicate the presence of behavioral problems at home or in school. Finally, you might wish to be aware that there is a children's impairment rating scale that was developed by individuals such as Greg Fabiano at the University of Buffalo, and you can find it at the website indicated here. This is a very useful rating scale in collecting information about various domains of impairment. Unfortunately, this rating scale does not have national norms, and so it cannot be scored up and used to obtain some quantitative index of how severely impaired the child is against other children of that age group. Nevertheless, it can be a quite useful rating scale for obtaining qualitative information about impairment. Now, another issue in the evaluation is determining the presence of comorbidity. What methods can be used for this? Well, obviously, this is also where a structured interview of various DSM disorders and their criteria would come in handy, such as the one in my ADHD clinical workbook. But ADHD children are also highly likely to have a learning disability. Indeed, up to 50% of them may have a disorder of reading, math, spelling, handwriting, or language. So, part of the evaluation should include a quick screen for these primary learning disabilities, such as using the Peabody Individual Achievement Test, or PIAT, the Wide Range Achievement Test, or the RAT, the WIAT, which is the Wechsler Individual Intelligence Test, Individual Achievement Tests, or the Woodcock-Johnson Psychoeducational Test Battery. So I do recommend that you take at least 30 to 40 minutes to quickly screen the child for the possibility that a learning disability may exist, whether or not ADHD is present. And that is because ADHD children have a high probability of having those learning disabilities. One also needs to do a quick screen for the presence of intellectual delay. So one can use a brief intelligence screening tool, such as the Kaufman Brief Intelligence Test or the Wechsler Brief Intelligence Test, in order to quickly screen for possible mental retardation or cognitive subnormality. If the child fails the screening test or gets a low score, then they can be brought in and given a more thorough intellectual battery. But one does not need to do full IQ tests as part of the evaluation of ADHD children, as most such children have normal intelligence, which could have been determined using a very quick 10 to 15 minute screening for IQ. Another issue, of course, as I've mentioned before, is the psychological adjustment of the parents. Now, in school settings, it would be inappropriate to evaluate parents for their own disorders. But in private practice or other mental health clinics, it is very important to determine the adjustment of the parents, because the parents' adjustment, as I've said, has some bearing on the child's own psychological adjustment, and also, as I indicated earlier, can even interfere with the types of treatment that are to be implemented for dealing with the child's problems. So what methods could you use to very quickly do a screen for parents who might have psychological adjustment difficulties? Well, in our clinics, we like to use the Symptom Checklist 90 Revised, which provides a screening for a variety of parent psychological difficulties. Also, we like to screen parents specifically for adult ADHD, because parents of ADHD children are highly likely to have the same disorder. Here there are several rating scales available that you can use. For instance, my own adult ADHD rating scale became available this year through Guilford Publications and has national norms across the lifespan for both men and women. You can also use the Connors Adult ADHD rating scales, which are also quite good. In addition, there are the Brown ADHD scales. But make sure that whatever scale you use, it has appropriate normative data for a U.S. population for men and women. Now, besides these screeners, one also might want to use a marital screening device, such as the Locke-Wallace Marital Adjustment Test. This is available in my book, Defiant Children. This is a quick screen for marital dissatisfaction. One would, of course, want to know if there are marital difficulties, because such difficulties might well be contributing to children's behavioral problems and might well interfere with efforts by the clinician in intervening with the child's problems, that is, with the child's treatment plan. Now, one also needs to determine the strengths and weaknesses of the child and of the parents, and this can be done through an interview with them about how they see their family functioning and how the parents see the child doing in various areas of development. As I've said, identifying the child and family's strengths and weaknesses is very important in assisting with putting together a treatment plan for the child. And of course, as already mentioned, it's important to establish the family's resources available in that particular community. And the method for doing so, obviously, is the interview with the parents. But of course, other information can be gathered through telephone contacts with social service agencies to determine what might be available in that community for treating this child's ADHD and related disorders. Let's talk now about the purpose and the contents of the parental interview, given how important it is for addressing many of the issues that were raised on the previous slide. Obviously, the purpose of the parental interview is to initially establish rapport and a relationship with the family, and most importantly, to gain as much information from them about the child and family issues and adjustment difficulties that may be of concern to them on the day of the evaluation. As I've said, it's also being used to detect the level of parental distress that may exist, and one could supplement the interview with the Parenting Stress Index if that is an important measure for the referral question at hand. But in general, one is using this interview to not only establish the information about the child's psychiatric problems, but also to determine the parent's own level of adjustment or maladjustment. In addition, one could use the interview to conduct a very specific behavior analysis about each of the child's behavior problems, what its antecedents are, what the consequences are that parents are using, in order to determine what kinds of recommendations might be useful for addressing that behavior problem. While this can be done as part of the initial parent interview, I prefer to leave this for a separate interview that precedes the beginning of behavioral parent training, where the information from such a behavior analysis is likely to prove very useful in planning out the kinds of contingency management strategies that are going to be recommended to the parents. Now, another purpose of the parental interview, as we've said, is formulating a diagnosis, or determining a differential diagnosis, that is, of ADHD from other disorders, and also developing a treatment plan. Finally, as you know, the parental interview also provides an opportunity for catharsis for the parents to ventilate a little bit about some of their distress with regard to dealing with this particular child. Now let's move on and look at the content of the parental interview. Some of this has already been covered previously, so I'll move through this slide relatively quickly. Note, I do like to have the parents interviewed alone rather than having the child present, as I think the child's presence sends a bit of a chill through the parents, which is to say that it makes them less willing to divulge information, particularly very sensitive or personal information about the child, in the child's presence. So many times I do not have the child present during this interview. I will interview the child separately. Obviously, one is using the interview to determine the parent's concerns about the child and the history of those concerns. One is also going to use it to review with the parents the child's development in a variety of areas of psychological development that are very important to evaluate. How is the child doing in their motor development? Is there any evidence of language delays or other difficulties with language? What about in visual, spatial, and mechanical ability? Does the child have evidence of any intellectual delays? How is the child doing in their academic skills and performance at school? And what about their social relationships with siblings and other children? I also review with parents whether there is any indication of emotional difficulties with the child. And then, of course, how is the child's health status, and so on. So I review each of these specific domains, asking parents whether there is any indication that the child might be having problems in these areas. In addition, one wants to review specifically with the parents the symptoms and other criteria for various child psychiatric disorders besides ADHD that may be comorbid with the child's ADHD. So review the relevant criteria for these disorders with the parents. Of course, one needs to obtain a history of the child's school functioning and any treatments that are received or have been received in the school environment. I like to do this year by year and get a detailed school history. I think it helps not only to provide very valuable information that's going to be useful in consulting with the school about this child, but also might be useful in determining the child's eligibility for various special educational services at school. Finally, I think it helps to provide a timeline for the parents that may help in their reports about other problems the child might have. And then, of course, if the child has received any services at school, the clinician would want to obtain a release of information from the parents to get those evaluations. One also wants to determine whether or not the child has received any treatments outside of school for various mental health problems, and if so, obtain a release of information in order to get those other psychiatric and medical records or evaluations. And then I like to interview the parents about any history in themselves or in their immediate relatives with regard to any other psychiatric disorders, as this can indicate what disorders the child may be at risk for. For instance, we know that children at risk for bipolar disorder have 7 to 8 times the likelihood of having relatives that also have bipolar disorder. So, such a history could be very helpful in the differential diagnosis of ADHD from childhood onset bipolar disorder. Finally, as I've said, we want to determine the pattern of the child's strengths, talents, interests, and weaknesses, and the parent interview can be indispensable for obtaining that information. And as we've said again, obtaining information about available resources is another subject that I explore in the parental interview. Now, I do like to interview the child, but I also do not place a great deal of weight in the child's reports about some of their problems because of the low reliability and validity that has been associated with children's self-reports. But I do use the child interview to establish a relationship with the child initially, to gain a first-hand impression of the child, their appearance, their personality, and of course their developmental status. Sometimes certain developmental disorders can be obvious in this evaluation. For instance, if the child has a language or an intellectual delay, or may be showing serious signs of a child's psychiatric disorder, such as childhood autism, these symptoms would be obvious in this interview. I also like to determine the child's perception of the reason for the evaluation. What have they been told about the purpose of this visit today? And then one can use the interview with the child in order to get information about various childhood disorders. Now, the childhood interview is not useful for determining the presence of disruptive disorders like ADHD, oppositional disorder, or conduct disorder, and that is because children often severely underreport the severity of their symptoms of these externalizing disorders. On the other hand, children's reports of their internalizing disorders have been shown to be quite reliable and valid. After all, who else is a better reporter of their internal emotions and mood states than the children themselves? Also, the interview with the child can be used, as I've said above, to gather information about the presence of any other developmental delays that might exist. But keep in mind, the reliability and validity of children's self-reports, particularly of their externalizing symptoms, is quite low until late adolescence or young adulthood, when it begins to approach the degree of validity seen in adult self-reports. Now, another purpose of this interview is the same as with the parent's interview, and that is to give some idea of the child's strengths and weaknesses, their interests, likes, dislikes, and talents. All of this information might prove useful in treatment planning. Now, besides the parent interview and the child interview, as I've mentioned, rating scales can be very useful in determining the degree of developmental inappropriateness of the child's symptoms. Here you see a version of the ADHD-IV rating scale developed by George Dupall and colleagues and published by Guilford Publications. This rating scale lists the 18 symptoms of ADHD as they are represented in DSM-IV, and parents are asked to rate the child's behavior on a scale from 0 to 3 in terms of the degree of frequency and severity of each symptom. There is also a teacher's version of this rating scale for collecting reports of the child's behavior at school. The scale can be scored up to get scores for degree of inattention, degree of hyperactive impulsive behavior, and an overall ADHD severity score. The scores can then be compared to the norms that come with the clinical manual for the scale. Norms are available for children, by sex, and at different ages from 5 through 18. Besides the ADHD-IV rating scale, as I've mentioned, 2 rating scales are useful for determining the pervasiveness of a child's behavior problems, not just the severity of their ADHD symptoms. And these 2 rating scales are the home and school situations questionnaires that can be found in my ADHD clinical workbook. Here you see the home situations questionnaire. And by the way, let me apologize for the quality of these images. This is the best my scanner could do at scanning in these rating scales for use in this PowerPoint presentation. But it does give you enough clarity to see the nature of these rating scales. Now, the HSQ that you see here assesses 16 different problem situations across the home and in the community. Parents rate each of these situations as to whether or not they are a problem by answering yes or no. And then if there is a problem present, we ask that the parents rate the severity of that behavior problem. So one can get several scores from this scale, for instance, the number of problem situations. One can also add up all of the numbers that you see circled on the right, sum them, and then divide them by the number of yeses, and that gives you what we call the mean severity score. So you have a measure of pervasiveness in the number of problem situations, and you have a measure of severity in the mean severity score. And then you can compare these scores to the norms provided in my clinical workbook for this rating scale. Again, this is a good scale at assessing pervasiveness of behavior problems. It's also quite useful in treatment planning, such as with behavioral parent training, in order to focus the interventions on the specific areas that parents are having difficulty with. On this side, you see the school version of the same questionnaire. This is the school situations questionnaire. It lists over on the left 12 different situations that children may have difficulty with in school. It again asks teachers to rate yes or no, is there a problem in those situations? And then, as with the parent version of the scale, the teachers are to rate the severity of that problem if it is present. The same scores can be obtained from this questionnaire as were obtained on the home situations questionnaire, and there are separate norms for the school situations questionnaire provided in my ADHD clinical workbook. Now, besides using rating scales like these to determine the degree of developmental inappropriateness, some clinicians like to use psychological tests that measure inattentiveness and impulsiveness. Such tests, for instance, are the continuous performance tests, and there are various such tests in the marketplace. This slide illustrates two of the more popular ones, and they are the Gordon Diagnostic System that you see on the left here, and the Conners Continuous Performance Test, which is a software program that runs on a personal computer. Both of these tests yield scores that can indicate inattentiveness and problems with impulsiveness. But I do not believe that these tests are useful for the reasons that I have given earlier, and that is that while abnormal scores on the test may indicate that some disorder is present, it doesn't necessarily tell you what that disorder is likely to be. The real problem is with false negatives. That is, if children get normal scores on these tests, it does not mean that ADHD is not present. This is especially true where ADHD might be coexisting with an anxiety disorder. Children with internalizing disorders are more likely to pass these tests than children who do not have an internalizing disorder with their ADHD. So I do not believe that these tests are useful for diagnosis of ADHD, even if they may be useful for other purposes. Some clinicians like to use neuropsychological test batteries for assessing executive functioning in ADHD children because there is ample evidence to suggest that ADHD is a disorder of executive functioning. For instance, studies using various neuroimaging devices indicate that ADHD is reliably associated with disruptions in the functioning of networks related to the prefrontal cortex or the executive brain. So at least based on neuroimaging research, ADHD is an executive function disorder. This might indicate that giving executive function tests ought to be useful for differential diagnosis of ADHD from other disorders. Indeed, many clinicians believe that executive function tests are the gold standard for measuring executive functioning. But unfortunately, this is not the case. Indeed, there is a paradox in the literature right now on this issue. For instance, if you give executive function test batteries to people with ADHD, you are likely to find that only about a third of them, or at most a half of them, are likely to fail these tests or place in the impaired range. For instance, getting a score in the bottom 7th% of the population, or more severe than 93% of the population. In contrast, when rating scales are given that measure executive functioning, nearly all individuals with ADHD who are clinic referred score in the impaired range. And in my Milwaukee longitudinal study, we found that of the ADHD children followed to adulthood whose ADHD had persisted, 65 to 75% of them fell in the impaired range on an executive function rating scale. So what's going on here? If we look at the executive function tests, most people with ADHD don't have such deficits. But if we look at rating scales of executive functioning, nearly all of them do. So which method is the best one to trust in evaluating executive functioning? Well, let's see. First of all, the executive function tests do not correlate well, if at all, with executive function ratings in daily life. Indeed, correlational studies indicate that these two methods of assessing executive functioning share less than 10% of their variation, which means they're really not measuring the same thing at all, even though they claim to be. And indeed, if we take the best combination of executive function tests, they share less than 20% of the variation with the results from executive function ratings. So whatever these two methods are assessing, they're clearly not assessing the same thing. Now, when we look at the relationship of executive function tests to various measures of psychological impairment, such as impairment in educational performance, or in work performance, or in social relationships, and so on, we find that executive function tests show little or no relationship to measures of impairment. Indeed, I've published several studies in the past year on this issue that found just this result. In contrast, when we use executive function ratings, they nearly always correlate significantly with ratings of impairment in various major life activities. So if the tests are used, they share little relationship with ratings of impairment or other measures of impairment, and therefore are not very predictive of impairment that people are likely to have. Whereas rating scales of executive functioning are likely to be 4 to 5 times more predictive of impairment in various major life activities. So at least if predicting impairment is an index of validity, executive function ratings have greater validity than do executive function tests. Whatever the results may indicate, it's very clear from the current literature on this issue that executive function tests are not measuring the same thing as executive function ratings. My own preference is to use the rating scales, and that is because the available indicates that they are much more indicative, that is, of impairment in a variety of major life activities in which executive functioning ought to be present than are the executive function tests. Indeed, it is my opinion that there is no need to conduct executive function test batteries for diagnosis of ADHD, whatever other uses these tests may have. Let me show you why. Here's the result of one of my studies done with 3 groups of adults. The first group of adults is a large sample, indeed about 149 adults diagnosed with ADHD seen in an adult ADHD clinic. Then we have a control group of adults seen at the same clinic who were not diagnosed with ADHD, but who either had other clinical disorders such as anxiety or depression, or who did have some ADHD symptoms, but they did not rise to the level of full diagnosis of ADHD using DSM-IV criteria. Many of them, in fact, probably had ADHD-NOS or a subthreshold case of ADHD. Nevertheless, they didn't qualify for the full disorder. And then finally, this study used a community control group. Now, look across here. On the left-hand side of the diagram, you see the scales from my rating scale of executive functioning known as the DEFs, for Deficits in Executive Functioning Scale. And then over here, you see a executive function test battery. And look at the dramatic difference in the results of the 2 methods. If the rating scales are used, nearly all adults with ADHD are impaired in 1 or more dimensions on the executive function rating scale, as are many of the adults in the clinical control group. And that's because other disorders can interfere with executive functioning, not just ADHD. And then you see down here that very few of individuals in the community control group fell in the impaired range. But look over here. The executive function tests show that very few individuals in these groups are impaired in their executive functioning. So, depending on which method you used, you could reach 2 opposite conclusions. Either adults with ADHD have executive function deficits, or they don't. Again, I think that it's the ratings that have the greatest validity because they are likely to predict impairment in various settings. Now, in case you think that this is just the results of a single study, here are the results of another study we published just a few weeks ago. This is the Milwaukee longitudinal study I mentioned earlier that has followed ADHD children up into young adulthood. And we have classified those children as either having persistent ADHD that you see here by ADHD-IV, non-persistent ADHD, which means that they did not qualify for the full diagnosis at age 27 in this study, but many of them did continue to have some symptoms of the disorder. And then finally, the third bar is the control group of children being followed up over the same period of time. What we see here is that individuals whose ADHD persisted often were impaired on the executive function rating scale. Indeed, the vast majority of them were impaired in at least 1 or more of the dimensions on this scale that you see along the bottom here. And we see that even those with non-persistent ADHD had higher ratings of executive function deficits than did the control group, although not nearly as much as those whose ADHD had persisted. But the real point here is the pattern. Look over here at the executive function tests used in this study, which was a quite different battery of tests than those used in the earlier study. And yet we see the exact same pattern of results. If rating scales are used, people with ADHD that persisted into adulthood are highly likely to have deficits in executive functioning. But if psychological tests are used to measure EF, most of the individuals did not have deficits on EF tests. So again, which of these is correct? I believe, again, because of the data available so far, rating scales are much more predictive of impairment in major life activities than are the psychological tests. So once again, this shows the problem with executive function test batteries and why I recommend against using them in diagnosing individuals with ADHD. Now let's turn to a different subject, and that is the subject of differential diagnosis. Let me give you a few diagnostic tips here that might be useful in differentiating ADHD from other disorders. First of all, ADHD has a very early onset in childhood. 99% of all ADHD cases develop before 16, 90% or more develop before age 12, and 65 to 75% develop before age 7. Very few mental disorders of childhood are likely to develop this early, with the exception of disorders such as bipolar disorder or autism or developmental delays such as mental retardation. And indeed, ADHD has an earlier age of onset than do disorders such as anxiety disorders or depression. So, one differential diagnostic tip is that if the inattentive, hyperactive, and impulsive symptoms have come on relatively early, and they are chronic and unremitting, as you see here, then it is likely to be ADHD rather than another disorder. Other disorders that interfere with attention are likely to produce more episodic interference with attention. Now, when I say that ADHD is a relatively chronic disorder, I'm referring to its symptoms. Impairment may well fluctuate over time or across settings, because how impaired one is from their symptoms is in part determined by the nature of the situation, the demands being placed on the symptoms, and any accommodations the individual might be receiving in that situation for their symptoms. But the symptoms themselves are not remitting in the case of ADHD, whereas impairments may well fluctuate over time. Now, I think one of the most important differential diagnostic tips for identifying ADHD from other disorders is that ADHD is at its core a disorder of inhibition or impulse control and self-regulation. Other disorders may interfere with inattentiveness, such as bipolar disorder, depression, anxiety disorders, panic attacks, and so on. So, inattentiveness is nonspecific and ubiquitous across disorders, and is of no help in differentiating ADHD from other disorders. But there are very few disorders of inhibition that start early and are chronic and unremitting. And while I know you understand that bipolar disorder is often associated with impulsiveness, bipolar disorder is a cycling disorder with periods of remission, and the impulsiveness often occurs only during the manic episodes. So ADHD is a chronic inhibitory disorder, whereas bipolar disorder is an episodic inhibitory disorder. Other than that, there are few, if any, other disorders of inhibition, and certainly none that start in childhood. So focus on inhibition to help identify legitimate cases of ADHD. Also, as I've indicated, individuals with ADHD have pervasive deficits in executive functioning as measured by rating scales, so those rating scales may also provide some diagnostic information. Other disorders, while they may interfere with executive functioning, are not likely to produce deficits across all dimensions of these rating scales, the way ADHD is likely to do. Let's look at some additional diagnostic tips that might be useful for you in differentiating ADHD from other disorders. Other disorders are likely to affect working memory, and so is ADHD. But typically, these other disorders do not produce chronic deficits in working memory that date back to childhood. For instance, we know that bipolar disorder can episodically interfere with verbal and nonverbal working memory. So can autistic spectrum disorders, which are likely to preferentially affect verbal working memory. Nevertheless, these disorders do not produce the severe, pervasive, chronic, and unremitting impairment in working memory, particularly in nonverbal working memory, that ADHD is likely to produce. Now, ADHD is associated with hyperactivity, particularly in childhood, in most cases. But hyperactivity is of little diagnostic value by adolescence or adulthood. It tends to diminish markedly with age, and by adulthood seems to become more subjective or internalized in form, leading to the individual reporting a sense of internal restlessness, or generally a need to be busy doing things. But their outward activity level is not necessarily more overactive, particularly in gross motor activity level, compared to other individuals, as it might have been in their childhood years. Indeed, my own studies indicate that fidgeting and restlessness while needing to be seated tends to become more and more associated with anxiety disorders after about 30 years of age. So all of this is to say, not to pay particular attention to hyperactivity as a diagnostic tip in adolescents and adults, as hyperactivity is likely to be of no value by that age, even if it is during early childhood. Now, many disorders interfere with emotion regulation, and ADHD is no exception. But ADHD produces what I have called a top-down problem in the management of normal emotions and in self-regulating them to be more socially appropriate. For more on this topic, take my course on this website on the importance of emotion in the diagnosis and management of ADHD. But for purposes here, understand that the problem ADHD individuals have is with impulsive emotions. The emotions they have are quite rational. Indeed, other people would have felt the same way they do in response to the same provocation. But other people are likely to inhibit strong emotion and then take active steps to moderate or downregulate that emotion through self-calming, self-soothing, reappraisal of the event, or other cognitive behavioral techniques for making the emotion more socially acceptable before expressing it. So ADHD individuals show rational but impulsive and more raw, if you will, emotions that are unmoderated by these secondary attempts at self-regulation. In contrast, mood disorders are likely to have much longer-lasting emotional states than these that are situation-specific in ADHD. And these problems are often likely to be quite severe, capricious, labile, and irrational. By irrational, I mean that the emotion is not necessarily explained by the event or situation. Indeed, the mood or emotion may be quite cross-situational. Oftentimes, parents, clinicians, or teachers do not necessarily know what may have triggered the mood or the emotion that the child is experiencing, and indeed there may need be no triggering event whatsoever. So, mood disorders produce irrational, severe, capricious, longer-lasting moods than does ADHD. The ADHD difficulties are with impulsive emotional reactions to events. So hopefully these diagnostic tips will help you to differentiate the emotional difficulties that go with ADHD, which are more top-down management of normal emotions, as compared to the moods and emotional problems seen in mood disorders, which are more bottom-up, severe expressions of mood in the mood disorders. Now, another issue to consider is comorbidity. And one needs to realize that comorbidity is very common in ADHD individuals, as I've indicated earlier. More than 80% of ADHD children and adults have at least one other disorder, and more than half of them have at least two other disorders. So part of the evaluation is going to be in identifying the comorbid disorders that coexist with ADHD. This can sometimes complicate differential diagnosis, because the individual is not trying to compare one disorder to another, but attempting to identify numerous disorders that may coexist. ADHD individuals are most likely to have oppositional disorder. They may have conduct disorder in up to 25 to 45% of ADHD cases. Antisocial personality, along with substance use disorders, anxiety disorders, dysthymia, depression, and even autistic spectrum disorders are more likely to coexist with ADHD. In some cases, although relatively rare, bipolar disorder, obsessive-compulsive disorder, or even psychosis or other thought disorders might coexist with ADHD in childhood or in adulthood. But again, these are far less common than the other disorders I've mentioned here. So individuals, as I've said before, need to be well grounded in their knowledge of differential diagnosis if they expect to conduct a thorough and appropriate clinical evaluation of children and teens. Now let's talk about the ingredients of the feedback conference following the evaluation. Here the clinician is going to summarize the parental concerns and the reasons for the evaluation, and then walk the parents through each source of information that was gathered and what the results indicate or what they reveal for the presence of certain disorders in this child. Then give the parents information about ADHD, of course assuming that ADHD is one of the disorders that has been diagnosed, and also about any other disorders that may have been diagnosed in the evaluation. The feedback conference can be used to give brief information about the nature, causes, course, and future risks of impairment that are associated with ADHD, and then refer parents to other more detailed sources such as paperback books, websites, fact sheets, and so on that might be useful for getting information to the parents about the child's ADHD. For more on the nature, causes, and course of ADHD, take my courses on this website that pertain to these topics. Now, in addition, the feedback conference is used to explain the various treatment options that the clinician is going to recommend for dealing not only with the child's ADHD, but dealing with the various domains of impairment that have been revealed in the evaluation. And of course, one needs to discuss with the parents whether or not these treatment options are even available or affordable to the family. Then there is a review of any other issues that came up during the evaluation that may be pertinent to discuss at this time. And then finally, the feedback conference concludes with any recommendations the professional has about connecting the family up with the other resources in the community that are going to be needed to carry out this treatment plan. Now, the feedback conference, I think, is being conducted to address certain essential issues or ideas. Besides going over the content that I've just discussed in the feedback conference, here are some other things to pay attention to in the conference itself. Obviously, improving parental knowledge about the child's ADHD is important, and I've already mentioned that. But I think it's also important during the conference to convey the seriousness of ADHD. As you may have learned from taking my course on this website on the life course impairments associated with ADHD, ADHD is a quite impairing disorder that often interferes with most, if not all, major life activities. Leaving it untreated poses risk for the child in all of these major life activities. And so I like parents to understand that ADHD is a quite serious developmental disorder. And yet I also like to instill in the parents a certain amount of acceptance of ADHD as a chronic developmental disorder, and a certain amount of compassion for their child that has this neurogenetically based disorder. As part of this instilling of acceptance, I teach what I call the 30% rule. You can learn more about what I advise parents to do with regard to dealing with ADHD at home in my course on parent counseling and parent training on this website. But one of the things I teach parents, even in the feedback conference, is the 30% rule. This is just a general rule that tells parents how delayed their child is likely to be in their self-regulation and executive functioning. And this helps parents to lower their expectations to this level rather than expecting that the child is going to be able to function at the level of a normal child in their self-regulation and executive functioning. So I tell parents that if they have a 10-year-old child, for instance, that 10-year-old really has the executive age or self-regulation of a 7-year-old, and that they can expect their child to be behaving like a 7-year-old with regard to these areas of functioning. Therefore, the parents need to lower their expectations to that level and not insist on normal functioning in self-regulation. I also like to use this feedback conference to gain some general indication of the parent's readiness to engage in treatment, what has often been called readiness for change, borrowing from Prochaska's work in the area of substance abuse. There are different stages of readiness for change, and these stages can be extended to parents and patients and not just to substance abusers. For instance, one stage of readiness to change is to whether one even accepts or denies the presence of a mental disorder. One can also be accepting of the presence of a mental disorder, but be at what is called the inquisitive or information-seeking stage of readiness to change. In other words, this person isn't ready to begin treatment. They're simply exploring information about the disorder, what it is, what its causes are, and so forth. Once they have such information, they might be inclined to start seeking information about treatment, but they're not quite ready for that yet. Knowing that a parent is at this level of readiness to change would then focus the feedback conference and other subsequent counseling sessions on providing the information they need, but one wouldn't necessarily launch immediately into starting interventions because the family isn't ready for that. Some families are ready for interventions, or at least are ready for more information about them, and are considering the possibility of enrolling in those interventions, even if they're not quite committed to that yet. Providing more information about the types of interventions, their effects and side effects, may be useful for addressing this stage of readiness to change. Certainly some families are already committed to change, and these are the families who are ready to begin treatment right away. There may even be some families that have already engaged in treatment, but who want to revisit the additional treatment plans because either the earlier treatment plan hasn't worked or hasn't addressed all of the domains of impairment, and so they're seeking a second opinion about a better treatment plan for the individual. I think it helps to know which stage along this dimension of readiness to change a family is functioning at, and then providing the information necessary at that stage to move them on to the next stage. I also believe that one of the essential components of the feedback conference is encouraging patience with the treatment process. ADHD is a life course disorder that has taken months to years to arise in this particular child, and so parents need to be patient with treatment because treatment can often take days to weeks to begin to produce its optimal effects, particularly if a package of treatments such as medications and psychosocial treatments are being put together. Parent training can take 8 to 12 weeks to implement, for instance. School evaluations can take months, and then getting special educational services can often take weeks before they're instituted. Although stimulant medications may work relatively quickly, non-stimulant medications can take weeks to titrate to the ideal dose. So I like to explain to parents the time course that's often needed for implementing treatments and encourage them to be patient as we put together the components of a treatment plan for this child, so that they don't become discouraged if the child's behavioral problems or ADHD symptoms are not reduced immediately. Finally, I think it's helpful to conclude the feedback conference with a message of hope. Yes, ADHD is a serious disorder. Yes, it interferes with many major life activities. Yes, it can be chronic and impairing over time if it's not treated properly. But parents need to know that at least 1/6 to 1/3 of ADHD children are likely to outgrow this disorder by their late 20s to early 30s. And so there is hope that over time, the individual, at least as an adult, may well outgrow the disorder, although 2/3 of ADHD individuals, at a minimum, are likely to retain their diagnosis into adulthood. But even for those who do retain it, I like to emphasize that ADHD is among the most treatable psychiatric disorders currently known. We have more treatments available for this disorder. Those treatments produce more improvement in ADHD symptoms and improve the symptoms in a larger percentage of cases than virtually any other outpatient disorder or even inpatient disorder currently treated. And so there's a great deal of hope with regard to the likelihood that treatments will produce some success in helping to manage this child's ADHD and increasing their effectiveness and success at dealing with various major life activities. I also let parents know that ADHD is one of the most well-studied disorders with regard to scientific knowledge available. Indeed, more than 10,000 studies have been published on the disorder, more than 3,000 of which have been published within the last 4 or 5 years. So we know a great deal about this disorder and about its management. And as I've said, there are more treatments that are more effective, producing more improvement in a greater percentage of patients than in any other group of individuals with psychiatric disorders. And indeed, ADHD patients show the highest rates of normalization in response to these treatments, particularly medications, than is the case with other disorders. So again, the bottom line is Use these messages to inspire hope in the parents. I also like to encourage among parents, particularly higher functioning parents, that they become advocates for their ADHD child. And indeed, teachers can serve in the role of advocate as well. Advocates actively promote awareness of ADHD among others. And if this is a parent, they could do so among relatives, friends, neighbors, and teachers, so that people understand that the child is not misbehaving simply because of poor parenting or willful disobedience. I also encourage parents to become advocates in pursuing available resources for their child, such as resources for information, treatments that may be available, and advocating for home and school accommodations in dealing with their child's disability. I finally encourage parents to remain connected to the ADHD patient as they grow up, and committed to helping the patient no matter what, even if the patient is resistant to treatment, even if the patient is non-adhering, for instance, to a treatment plan. Parents should not use their relationship with a child as an ultimatum for whether or not the person participates in treatment. Again, I encourage acceptance of the individual, waiting for windows of opportunity to give advice to the individual, provide assistance wherever possible, particularly when the individual is interested in receiving treatment, and helping to gain access to treatments for the individual when they are interested in and cooperative with those treatments. So keep a relationship with the patient over time, and you will find that that relationship may well benefit the individual in helping to cope with and treat their ADHD. Thank you for taking this course on the assessment of ADHD in children and adolescents. I invite you to take other courses I have prepared on this website at your convenience. I also invite you to explore various other products that I've created for ADHD, including my new rating scales for evaluating adults with ADHD, for evaluating executive functioning deficits, and for evaluating functional impairment in psychosocial domains, using the rating scales that you see at the top. You can visit my publisher's website, which is guilford.com, to learn more about these and other products I have with regard to ADHD. Thank you again for taking this course. Goodbye.